I'm not sure I can discuss what will happen in the next 20 years. I could say what could happen in the next 12 months or so I will try to do this in the next 5 minutes. So of course we have to make our approach based on red flags more robust, as we discussed a few seconds ago, so I will skip this. We might wish to define more simple sets of criteria to show dissemination in space and time. We have seen that the criteria available are very nice, are very robust, but they are pretty complex. So one step research is taking is to try to simplify this approach to keep good diagnostic accuracy with more simplicity. And the third area is to find additional markers which might aid in differential diagnosis. So I will just briefly touch these last two issues. One approach is to simplify dissemination in space. This has been done by Americans. You know that Americans like to simplify things, so they started to simplify dissemination in space. This is the, these are the classical McDonald criteria, which requires the 9 lesions, the gadolinium enhancing lesion, the infratentorial lesion, and so on and so forth. So they said, just pick up 3 lesions is enough. And you can see that sensitivity improved quite a lot, but specificity dropped dramatically, meaning that if you use such a simplified approach, you will make an over-diagnosis of MS in many people that don't have MS. So this is something that is not acceptable, I would guess. There is a tendency also to simplify dissemination in time. This will be presented by Alex Rovira in this Congress in the next couple of days. So I will go quickly through it. This is the idea to use just a single MR scan to show a dissemination in time instead of using 2 or 3 as we are doing now. And you can see these are very preliminary and early data, but sensitivity and specificity are pretty good, both if you use an MRI within the 30 days after disease onset or after 30 days from the disease onset. So there is space to simplify, I guess, the criteria for dissemination in time. But the best approach to, I guess, for simplify the overall set of criteria is the one from Swanton et al. From the UK, Queen Square. So they are like Americans, they like to simplify, but they do proper job. And they suggested to show dissemination in space by showing at least 1 lesion in each of at least 2 of the classical locations for MS, so periventricular, subcortical, posterior fossa, and spinal cord. Or, of course, these lesions should not be symptomatic. And dissemination in time just showing a new T2 lesion on whatever subsequent MR scans you might obtain. And these are the results that have been published very recently in the Lancet Neurology. And you can see that by using these new simplified criteria by Swanton and co-workers, you can improve sensitivity compared to the previous criteria. You don't lose very much on specificity, so your diagnostic accuracy is even better than previous sets of criteria. So you have a simplified criteria, and which also behave better than the previous one. So this might be a nice way through for the future. The other topic is to find new disease biomarkers, and this might be found using a very high field strength MRI. So these are images given to me by Dr. Kangarloo from the Ohio State University. These are post-mortem images obtained at 8 Tesla, where you can start to see lesions from MS very well. And some of these lesions show the typical Dawson's fingers that have been shown by pathologists 100 years ago. And this might be, well, an additional typical feature that we might wish to see in future MR scans to improve our ability to make a diagnosis when high field strength magnets will be available everywhere. This is again the same pictures, but showing you that there are many cortical lesions in this brain from an MS patient. So again, these additional lesions that can be seen now with these magnets and with new sequences might be an additional hint to improve ability to make a diagnosis, because we have now sequences such as this one, which is a double inversion recovery sequence, where you can see on routine average scanners lesions in the cortex that can be seen with very high field. And we are also we have available MR scanners at 3 Tesla, which again, with the less accuracy, but pretty well as well, can show lesions in the cortex. So this might be an additional way to improve diagnostic certainty. So I can move on to the conclusions, and just to summarize what I said. I guess that conventional MRI, the MRI scans we saw in the last half an hour, provides useful pieces of information to achieve an MS diagnosis earlier and more confidently than on a clinical ground alone, and so to avoid frustration as the one Juliana had to live in the past. Guidelines and criteria to use conventional MRI at best are available and have been validated in several studies, and are a robust approach for making a diagnosis. Additional work is in progress, at least in 3 areas, to expand the concept of no better explanation, to simplify the requirements to show disease dissemination in space and time, and to define new disease biomarkers, such as using high-field magnets. And of course, all of this is central to select and monitor early MS patients amenable to treatment, in the view that early treatment might be much more powerful than late treatment in modifying the course of the disease. This is on one side, and on the other side, to establish appropriate treatments for patients with other diseases that may mimic MS, but they're not MS. And with this, thank you very much for your attention.
Thank you very much, Massimo, for a very clear and very concise presentation. Now that you're all expert in MRI, of course, perhaps you'd like to ask some questions. Any comments or questions about the topic of diagnosis? Or are you all going to stay very quiet? There are microphones along the side here. Anything you like, you can ask Professor Filippi anything you like, and he has to answer because he's standing there. No?
Yes.
Well, I prefer if you, do you think you could get to the microphone?
I'm very liberal, but Alan not.
Yeah? There's just one down here beside you. That'll be great. And somebody else over here is going to ask a question. Just be thinking about, yep, you can come up to the microphone here. That's great.
Okay.
Brilliant. Thank you very much.
So I have a little question about magnetic resonance diagnosis from my own experience. I would like to ask if it is possible to detect inflammation activity without gadolinium scan. So I was my latest MRI was done 5 years ago. And this year I was in another scan, but without gadolinium. My doctor has no physical data, no computer data, nothing. But she told me, you have now inflammation. I think it is not possible. What do you think?
So if I understood correctly, you had a scan 5 years ago, and you had a new scan recently. And your doctor said, without gadolinium, and your doctor said you have inflammation. So